not fully expanded. In other words, let's go deeper into these. So why these DNA cutoffs? For example, we have seen if NDHB-EAG was positive, for example, an immune active phase. We know there are 4 phases. One is tolerance phase, immune active phase, immune control phase, and immune escape phase. But in immune active phase, EAG was positive and DNA cutoff was more than 20,000, whereas here EAG was negative and DNA cutoff was greater than 2,000, not 20,000 here. In HBEAG positive patients, for example, these A immune active phase, they have EAG positive. That's why they have a higher viral replication. So that's why we have kept cutoff of more than 20,000. Whereas in immune escape phases, they often have mutations in the pre-core region there or core promoter regions. That's why they have less DNA but more liver damage. That's why we have kept this DNA cutoff as more than 2000. So lower DNA but more deadly because of escape mutants. And why ALT more than 2 upper limit of normal? Why not treat all elevated ALT? Because you see, mild ALT rises can be non-specific. For example, with fatty livers, with other medications, or with alcohols, these elevations can occur due to that. So 2 times upper limit normal is a confident marker of HBV related hepatocyte injury. So ALT must scream, that is, this is a scream, before it's treated unless biopsy whispers moderate to severe hepatitis. So there is this role of fibroscan in gray zone. As per AASLD and EASL criteria 2024, what they have told us is ALT is less than 2 times upper limit of normal but DNA is elevated. So you see, this is a gray zone. So in such a case you have to do fibroscan, which is a non-invasive investigation. If LSM on fibroscan is greater than 7.5 to 8.5 kilopascals, then you have to treat because it is suggestive of significant fibrosis. So this was the gray zone. So fibroscan is the stethoscope of the liver in 2024 medicine. Now we know tenofovir DF or tenofovir alafenamide, they are the first line, potent plus they have got higher barrier to resistance. Entecavir is also first line, it's potent and safe. Pegylated interferon has got now limited use. Why? Because anti-HBAAG positive young patients, because of this side effects, it has limited use now. Why treat in pregnancy if HBV DNA is more than 200,000? Because risk of mother to child transmission increases significantly. So you have to start tenofovir at this 28 to 32 weeks. Neonate should get HB immunoglobulin plus HBV vaccine within. So both vaccine plus immunoglobulins is to be given to the neonate within 12 hours of birth. So if HBV DNA is more than 200,000, there is mother to child transmission. So in mother you have to start tenofovir at 28 to 32 weeks. And we treat cirrhotic patients regardless of DNA and ALT because even low DNA levels cause progression in cirrhotic patients, and there is risk of decompensation or HCC, and that's very high in cirrhotic patients, and that's why antivirals come in handy. They stabilize disease and prevent flares. So the mental model you can remember is scarred liver can't take any more hits, so that's why it's to be treated always. And when to stop therapy, this is an advanced mastery. You, as per Harrison 22nd and EASL criteria, HBEAG positive um, and HBeAg negative. If you see, why can't we just stop treatment in everyone after some time? Because hepatitis B is not eradicated. You have to remember this thing. So it's not eradicated with current antivirals. It just gets suppressed. So key fact is HBV DNA integrates into hepatocyte nuclei. Antivirals suppress replication but don't eliminate this core DNA or this CCC DNA, that's covalently closed circular DNA. It doesn't eliminate this. So the immune system must take over before you can stop treatment safely. So there are two groups. You see, two groups are there. We have E antigen positive and E antigen negative. Think of these as different immune landscapes. When this when we see this case, HBeAg positive patients, what happens? These patients are usually in immune active phase, and there will be immune active, there will be DNA will be present, ALT will be raised, and so when you treat, goal is to achieve seroconversion, that is HBeAg negative. So loss of HBeAg plus appearance of anti-HBe antibodies. So this is the goal here in these patients. But once that happens, you continue antivirals for 12 to, so you achieve first seroconversion. Once this is achieved, seroconversion means EAG becomes negative and the corresponding antibody becomes positive. And once this happens, when seroconversion occurs, 12 to 18 month, called consolidation phase, this antiviral is still to be given. If patient remains stable, that's normal ALT, undetectable DNA, you can consider stopping treatment. So EAG positive, there is eventual exit possible, but only after seroconversion plus 12 to 18 month of quiet liver. So when liver is quiet for 12 to 18 months, then you can stop. So this is as per Harrison 22nd and AASLD 2024 confirms this as the standard approach. So what to monitor after stopping? You see, ALT and HBV DNA is to be monitored every 3 months for the first year. Why? You had to watch for relapse. There is second this landscape, EAG negative. These patients often have this precore or core promoter mutations. Virus continues replicating without producing E antigen. So you see, we were discussing here immune active phases, and here we are describing immune escape phase where EAG is negative. These are the only two phases where we have to treat. In other two chronic HBV infections, they are the inactive phases, that is immune tolerant and immune control phases are both inactive phases. They are also called as chronic inactive hepatitis phases, and they are simply monitored, whereas immune this active phase and immune escape phase, they are both to be treated. That's why we are dwelling into when to stop treatment in EAG negative, that's immune escape phases, because we know they are harboring these precore or core promoter mutations, and know that immune system never fully controls the virus here. So even if DNA is low and ALT is normal, there is still risk of relapse, and risk of relapse is high in these cases. Thus here we take a different management path here. What we do is we give lifelong treatment. It's often needed here. So EAG negative means endless antiviral era. EAG means endless antiviral era, because no seroconversion milestone is there to guide you, because there is no guidance. Here we knew that something is going, some there is no seroconversion occurs, but here we cannot know seroconversion because EAG is already negative. So when to stop, to summarize, when to stop this HBV treatment, goal is HBeAg seroconversion plus appearance of antibodies, and that's how you know that viral suppression has occurred. And you stop after 12 to 18 months of stable post seroconversion, and risk of relapse is moderate in EAG positive. So risk is moderate here, but risk is very high here. You see, in here we see relapse, but if for instance ALT flare occurs after stopping treatment in especially cirrhotic patients, that can lead to decompensation. That's why we don't stop treatment in cirrhotic patients. So let's discuss few questions. A 25-year-old HBeAg positive with DNA of more than 20,000 with ALT of 150. You started this patient on tenofovir. So this patient has been started. After 2 years, EAG was lost. That means what? Seroconversion has occurred, and ALT has. So after 2 years, what do you see? EAG lost, anti-HBe has appeared. Anti-HBe has appeared, and ALT is normal. DNA levels undetectable. So what will you do? Will you stop? No, you will keep him on these antivirals, that is tenofovir, and you will be monitoring this KFT and other parameters because it causes osteoporosis, and you will give this for 12 to 18 months as consolidation phase. Then you will consider stopping. Now case second is, for 25-year-old with EAGE positive DNA, for example, more than 20,000, ALT 150. You started on tenofovir, but ALT what you started on tenofovir, but HBeAg is still negative. So there is no seroconversion. You have to continue the treatment. Case 3 is 45-year-old male, EAG negative, DNA 3500, ALT 60. Started on entecavir. After 3 years, DNA undetectable. ALT normal. So what will you do? You will still continue the treatment indefinitely unless part of a stopping trial that has not come yet. Now let's delve into another thing. This acute hepatitis B is not treated the same way as chronic hepatitis B. There is a confusion. In acute hepatitis B, we know that most people clear the virus spontaneously, and antiviral treatment is usually not required. It's usually not required in case of acute viral hepatitis because most patients clear the virus spontaneously. So supportive care is enough in most cases, but in chronic hepatitis B, persistent lifelong viral integration occurs. There is a concept of integration. So treatment decisions are based on ALT, DNA, EAG, fibrosis, cirrhosis. So goal there is you have to suppress the virus and prevent cirrhosis and prevent ACC. These are the goals. You cannot eliminate. So if we will delve into acute hepatitis B, we know it is acute means recent infection less than 6 months. Often transmission occurs through multiple sexual partners or parental methods, and symptoms are often they present with fever, for instance jaundice, and fatigue sometimes, and spontaneous recovery is the rule. Greater than 90% in adults clear the virus, and HBsAg is present initially, but usually it gets cleared, and anti-HBs is formed in recovered cases. And we already described in vaccinated and recovered cases. Vaccinated will have anti-HBs positive only, whereas This will have antibody against S and antibody against core. So goal of treatment in acute hepatitis is supportive treatment until immune system kicks in and clears the virus. Antivirals are rarely needed, only they are given in severe or fulminant hepatitis, whereas there is risk of HCC uh, in chronic, but it's not present here. No long-term risk if virus has been cleared. So treatment of HBV acute is generally not required. Antiviral therapy may be considered only in severe acute hepatitis. For example, if a patient has developed acute liver failure or is immunocompromised patients. So, two indication of starting antivirals in acute viral hepatitis B is if a patient has severe acute hepatitis. For example, if patient develops acute liver failure, coagulopathy, encephalopathy, or in immunocompromised phases or patients. So acute means you just have to wait and support, and chronic is evaluate and suppress. So when do you actually treat acute hepatitis B? Situations like fulminant hepatitis you will treat because you have to prevent liver failure and death. Also in severe acute hepatitis where patients will have INR raised and encephalopathy, so you have to prevent decompensation. In immunocompromised state, for example HIV and transplant patients, you have to treat because you have to there is a risk of chronicity. And in pregnancy with acute HBV, you consider treatment to prevent vertical transmission. So treat acute HBV only if the liver or immune system is crashing. So what are the tips that will make your tips or clues that will make you think what's going on? For example, if an adult patient with acute hepatitis with jaundice, ALT more than 1000 SAG positive, it's HB, it's obviously acute. Whereas ALT is rising, INR is more than 1.5, encephalopathy is there, so this is fulminant hepatitis. HBV in immunosuppressed patients, for example on chemo, there is risk of reactivation or there is risk of chronicity. So chronic HBV with ALT 60 DNA 1000 EAG negative, this immune escape. So in the battle analogy is acute HBV, the immune system is actively fighting and winning, so don't interfere unless liver is losing. Whereas in chronic HBV, the virus is hiding and eroding the liver slowly. You must suppress it stealthily and long term. Now there are two things that might confuse you later on: severe acute hepatitis, for example B, and fulminant hepatitis, also termed as acute liver failure. Severe acute hepatitis is there is hepatic inflammation with INR prolonged, but mental status is normal, so encephalopathy is not there. Encephalopathy is absent in severe acute hepatitis. Liver is under stress but still compensating. Patient may still recover with antivirals and monitoring. Prognosis is good with treatment. But in case of fulminant hepatitis, that's acute liver failure, INR is prolonged, so there is hepatic encephalopathy, there is confusion or coma, liver is failing, brain is affected. So here liver is failing, that's why encephalopathy has occurred, but here liver is compensating. This patient needs ICU care, urgent antivirals and transplant. Urgent antivirals and transplant evaluation. Prognosis is there is high mortality without transplant. So fulminant hepatitis is acute. Fulminant hepatitis is onset of hepatic encephalopathy within 8 weeks of jaundice plus INR more than 1.5, no prior liver disease. And severe acute hepatitis is acute HBV plus INR more than 1.5 but no encephalopathy. So encephalopathy is the key switch from severe to fulminant. So if you come across a young adult who has jaundice, young adult for example, jaundice ALT for example 1800, but mentally alert, so this is severe acute hepatitis. Whereas some patient, this for example, some patients may develop later on confusion or coma, then they have entered into a new thing called as fulminant hepatitis. So if the brain joins the liver, it's fulminant. If only the liver is struggling, it's severe acute hepatitis. So you have to watch for signs like asterixis, that's flap, and altered sleep wake cycle, and agitation, that are the signs towards development of encephalopathy. The patient is going into fulminant hepatitis. And fulminant hepatic failure is one of the few true emergencies in hepatology, and timely initiation of antivirals, ICU support, and transplant referral immediately will save the patient. And most common viral causes are HBV, HEV, and HSV. So HBV causes this fulminant hepatitis or hepatic failure. Also HEV in pregnant females causes this, and HSV